The subcommittee will come to order. Good afternoon. Thank you to our witnesses for being here today to discuss a crucial issue before us, ensuring access to quality post-acute care for seniors in terms of Medicare. Millions of Americans rely on post-acute care to recover from serious illnesses, surgeries, and injuries. In fact, 40% of Medicare beneficiaries who are hospitalized use post-acute care services following their hospital stay. Quality post-acute care can often result in patients' better outcomes and a better life. For example, patients discharged to a nursing home have a lower rate of death and a lower rate of hospital readmissions than those receiving care in a less specialized setting. 58% of home health patients report improvements in their ability to engage in daily life activities. Long-term care hospitals offer specialized services, and inpatients rehab facilities can help patients recover from injuries. Some of these providers are even leveraging innovation like telehealth, which is very big, to allow post-acute care patients to receive quality health care at home. Just 2 weeks ago, Congresswoman Carol Miller introduced the bipartisan Hospice Recertification Flexibility Act. This important legislation will allow hospice providers to use telehealth to recertify their hospice stay from the comfort of their home, and I look forward to seeing this flexibility become a reality. We must focus on ensuring that patients receive the right care, the right place, at the right time, the right price. Our Medicare program has changed over the past decade, and we are here to make sure that patients have sufficient access to care. At the same time, we must conduct oversight to make sure these services are delivered timely. I commend Representative Panetta and Van Dyne for working together to ensure these programs operate as intended to conduct oversight in terms of hospice providers. Strengthening our post-acute care system is critical to improving outcomes and reducing health care costs. I look forward to the hearing today to discuss the importance of the issue, and I'm glad to recognize the gentleman, a good friend from Texas, Mr. Doggett, for his opening statement.
Well, thank you, Mr. Chairman, and thank you for your consistent courtesy and professionalism. This hearing is focused on what happens to Americans after they've been treated at the hospital. We have a number of important portions of the healthcare industry here to discuss different aspects of post-acute care. But I don't believe you can talk about access to post-acute care in America today without talking about Medicaid. It is the primary payer for this care. It covers 2/3 of all nursing home residents, 60% of all home and community-based services. It pays for the long-term support for 9.3 million seniors and individuals with disabilities. And that care is on the chopping block. $880 billion proposed to be taken out principally from Medicaid in the Commerce Committee. The plan that Republicans are offering for skilled nursing homes is one to take the nurses out of the nursing homes, as they promise to pay for some of these actions by repealing the extremely modest minimum nursing staff standards that were adopted by the Biden administration. After giving private equity-backed nursing home operators carte blanche to reduce care and slash staffing in the fashion of Musk's Department of Government evisceration, Republicans will be cutting a significant amount of the financial backing for each of the different aspects of health care represented today. After repealing the minimum staffing requirements, Republicans intend to cut the funds that pay for nurses and ensure that our most vulnerable loved ones are not left on the hook for a nursing home stay that can cost $100,000 a year. This post-acute care plan amounts to a prescription for a mountain of medical debt and a preventable death sentence for some people. Last week, I heard from one concerned Austinite who resides in a nursing home. Her closest family member lives in Florida, and she has no means to travel back and forth there and pay for her nursing home if Medicaid is slashed. She understandably told me, quote, "I'm very afraid." Many adult children have written me concerning a loved one, a parent with dementia or Alzheimer's. Again, unable to personally provide the 24/7 care that is necessary. These are folks who don't know how they'll get by without Medicaid. Similarly, I've heard from the parents of children with a variety of complex medical conditions and disabilities who require home health aides, costly therapies, and eventually may need to reside in assisted living. They seek assurance that their children will live with dignity, health, and the support that they deserve. The only thing I'm sure of is that if enacted, the Republican budget plan will harm each of these families. The Independent Congressional Budget Office confirmed this last week. After setting aside Medicare spending, which Republicans have promised not to touch, through the trillions they would add to our national debt endangers the stability of those programs also. It was pointed out by the Congressional Budget Office that aside from this direct Medicare spending, 93% of the funds under the jurisdiction of the Commerce Committee, which has been told to cut almost $1 trillion in order to finance more tax breaks out of this committee, 93% is Medicaid, and of the remainder, 7% is CHIP. So health care is on the chopping block, particularly post-hospital acute care. No matter how you slice it, this budget demands cuts that will harm so many Americans, all to further enriching a handful who are already doing quite well. Under this budget, we don't just have to worry about what happens after the hospital. There will be acute need everywhere, widespread. I look forward to hearing from each of our witnesses, though I'll be interrupted by a quick trip to the floor on another bill from Ways and Means that was scheduled, unfortunately, at this time, because millions of people are at risk from this Medicaid cut. Thank you, Mr. Chairman.
Thank you. I now introduce our witnesses. First, I will recognize Mr. Arrington, who will introduce the first witness.
I want to thank the chairman. I will say you did a pretty good head fake just then. You said you wanted your good friend from Texas to make an introductory remarks. So I hit my little button over here, and turns out your friend from Texas is Lloyd Doggett.
Yeah.
And then you stuck me down here in the corner. So this is what happens when you're the budget chairman in a budget reconciliation year. You end up in the corner.
Get over it, will you?
Yeah. I have the privilege and honor of introducing a very close friend of mine and a fellow West Texan in Dana Madison. And the Madison family, she's joined by her husband, Ronnie, if you would wave to everybody. The Madison family, they don't get any better than the Madisons in West Texas. And I think you'll find that Dana represents the very best of our people out west of I-35 in the great state of Texas. They work hard. They're committed to serving their patients. They're committed to excellence. They love the country. They want America to win. They want us to have the best, most efficient healthcare system. And they understand that ecosystem and how to make it work better to provide greater access, better quality care, and bend the curve on spending. And so I'm delighted she's here today. I expect that she'll give some very insightful counsel to this committee. And Dana, it's an honor to serve and represent you and the Madison family. They have a 5-star rated home health agency, 5-star from CMS. And they've been in this business almost 40 years. Dana's a nurse, so she's been practicing medicine for about that amount of time. So anyway, you know how to pick them, Mr. Chairman, and you got a winner in the Madison family. God bless and go West Texas.
Yeah. Mr. Smith from Nebraska will introduce our next witness.
Thank you, Mr. Chairman. I'm pleased to welcome Mr. Paul Dongilli, the CEO of Madonna Rehabilitation Hospitals. With locations in Lincoln and Omaha, Nebraska, Madonna has served Nebraskans from across the state since 1958, and its cutting-edge and world-class treatment and technologies have made it a national destination for rehabilitation. Their Lincoln campus is a state-of-the-art facility and one of the only locations in the country to combine skilled nursing, inpatient rehab, and long-term acute care services under one roof, spanning the full continuum of post-acute care. Mr. Dongilli, thank you for being here today, sharing your insights, and certainly your entire team. that, like I said, offers world-class treatment for so many folks, and we certainly look forward to your testimony. Thank you again.
Thank you, Mr. Smith. Jonathan Fleece is President and CEO of Empath Health, which provides home health care and hospice services to more than 23,000 patients in my area. Mr. Fleece also serves on the board of Florida's Hospice Association. I have enormous respect for his intellect. He does a lot of great things in our community. My wife's had an opportunity to be on board and participate, but really appreciate you taking the time and coming up here. I know you're a busy guy. Lisa Grabert is a visiting research professor at Marquette University. Eric Carlson is the Director of Long-Term Services at Justice and Aging. I want to thank you for joining us today. Your written statements will be made part of the hearing record, and you will have 5 minutes to deliver your oral comments, and try to keep it, if you can, to 5 minutes. So with that, Dr. Madison, you are now recognized.
Thank you. Good afternoon, Chairman Buchanan, Ranking Member Doggett, and distinguished members of the subcommittee. My name is Dana Madison. It is an honor and a privilege for me to be here today representing the home health industry. I'm the administrator of our family-owned agencies that serve both urban and rural patients in the Texas Panhandle and the West Texas region. I've been a registered nurse for 41 years. I have a bachelor's of nursing, an MBA in healthcare, and a doctorate in nurse practice leadership from Texas Tech University Health Science Center. I served as the president of the Texas Association for Home Care and Hospice from 2010 to 2012, have served on the board of directors, and currently co-chair the Medicare Committee. I started my first home health agency in Lubbock, Texas 31 years ago. Most patients had traditional Medicare coverage and reimbursement was cost-based. The Balanced Budget Act of 1997 dramatically changed the reimbursement model for home health care. It created the interim payment system that went into effect in 1998. The cost-based reimbursement methodology was further complicated by an annual capitation per patient. Over the next year in Texas alone, 70% of the agencies closed, and nationwide, about 30%. In January of 2000, the prospective payment system went into effect with the goal of aligning reimbursement with patient needs. CMS also implemented a new assessment tool, OASIS, a baseline for measuring outcomes. It also included a small rural add-on payment for rural patients, which was helpful, but rarely covered the cost of the windshield time of our staff. It is not uncommon for our staff to drive over 400 miles a week to see their patients. This rural add-on was taken away, phased out in 2022. 2020 will forever be remembered for the COVID-19 pandemic and resulting public health emergency. But there were other challenges. In January, a new payment system, the PDGM, started. Based on a 60-day period of care, PDGM changed reimbursement to 2 30-day increments with minimum service requirements. Claims volume doubled, and we had to add administrative staff. January 2020 also marked the beginning of the public health emergency. Our employees were taking care of up to 80 COVID patients a day in their homes. Costs skyrocketed for both scarce labor and supplies, but we were determined to do our part to free beds of the hospitals for the sicker COVID patients. In my opinion, home health met and exceeded expectations in helping this country through the emergency. Finally, in March of that same year, RCD began in Texas, which required pre-authorization for all traditional Medicare patients. We had to add administrative staff once again. In 2023, CMS introduced home health value-based purchasing. Under this, we're graded on improvement in functional scores, rehospitalization, and customer satisfaction, and can receive up to a 5% bonus or a 5% decrease in payments. This has the potential to eliminate home health agencies that are not producing good patient outcomes. Medicare Advantage plans cover approximately 50% of the Medicare-eligible patients that we serve. Most of these plans reimburse at a rate below our costs, and many are limiting or denying care. These plans do offer services not covered by traditional Medicare, and one plan offers up to 20 hours of unskilled care per week, which helps the patient stay at home. I'm very passionate about what we do and the positive impact that home health has on the overall healthcare system. The average patient that we serve is a 79-year-old female that lives on a limited income. My husband and I come to Washington several times a year and have for the last 20 years to represent our patients. We have never asked for an increase in reimbursement, but simply a reduction in reimbursement cuts and regulations. For the past 2 years, CMS has implemented a permanent payment cut in reimbursement because they contend that home health was overpaid in 2020 and 2021 during the COVID pandemic. MedPAC annually reports to Congress that home health margins are 20%. I asked Congress to instruct CMS and MedPAC to include all costs for all Medicare-eligible patients to show the true picture of home health margins, which are closer on average to 5% nationally. I will conclude with these takeaways. On average, a 60-day period of care with home health costs less than one visit to the emergency room. Most senior citizens in America want to receive care in their home. Our country continues to have a critical nursing shortage that was exacerbated by the pandemic. The utilization of telehealth and home health care must become reimbursable. And I believe that home health care is both cost-effective and can be at the forefront to help our country meet the challenges of our aging population now and in the future. Thank you very much.
Thank you, Mr. Dongilli. You are now recognized.
Chairman Buchanan, Ranking Member Doggett, and members of the subcommittee, thank you for the opportunity to participate in today's hearing. I also want to thank Congressman Smith for his leadership and strong support of Madonna. My name is Paul Dongilli, and I am President and CEO of Madonna Rehabilitation Hospitals. Our services include long-term care hospitals, inpatient rehab hospitals, and skilled nursing facility services.
Excuse me, can you speak into the mic? Thank you.
Thank you. I'd like to share a patient's story. 73-year-old Randy Lemire came to Madonna after spending 2 weeks at a South Dakota hospital. Randy was hit by a car while riding his bike and arrived at Madonna requiring a tracheostomy and a ventilator to breathe. He had also sustained a severe brain trauma and required a craniotomy. After 3 months in our LTAC, Randy was transferred to our rehab hospital. 5 months after arriving, Randy walked out of Madonna and returned home to South Dakota with his wife, Gloria, of 54 years. This story is a real-life example of the different and distinct levels of post-acute care offered at Madonna and how patients move between them. Efforts to advance an advanced, unified post-acute payment system have proven very difficult and complex. There have been beneficial reforms specifically to the rehab hospital and SNF payment systems. However, LTAC payment systems have not been similarly reformed, with changes instead focusing on payment criteria, resulting in financial concerns and hospital closures. Alarmingly, the number of LTACs decreased from 438 in 2015 to 341 in July 2024. An additional 17 closed in 2024 or announced that they would in 2025. The bulk of LTAC closures occurred when CMS implemented a new dual payment criteria system as required by Congress. The dual system criteria likely misses patients who would benefit from an LTAC. A financial strain for LTACs, like Madonna, is the high cost outlier fixed loss amount threshold. LTACs can get an extra payment to offset financial loss associated with extremely high cost cases. But over the last 2 years, the amount a hospital must lose before they are eligible for the payment has doubled from about $38,000 in fiscal year 23 to $77,000 in fiscal year 25. One or two $70,000 losses is potentially financially devastating, especially for independent, small, and rural LTACs. The National Association of Long-Term Hospitals is immensely grateful to Congresswoman Miller, Congressman Hearn, and Congressman Boyle for introducing legislation to provide relief and stability to the industry. Specifically, NALTH asks the committee swiftly consider legislation to reform the method for determining the high-cost outlier fixed loss threshold, expand the standard rate to additional high-acuity patients, and provide the ability to directly admit patients to an LTAC from a critical access hospital. Such legislation cannot be offset by reductions within the industry. Between 2016 and 2022, Medicare fee-for-service LTAC spending decreased a cumulative $11 billion. There's simply no juice left to squeeze. Congress should also urge CMS to continue to refine the post-acute care payment system to ensure that payments reflect the uniqueness of each setting, the case complexity, and associated high resource use. I'd like to briefly discuss Medicare Advantage. MA plans' prior authorization and denial practices are limiting access to post-acute care. Many MA plans deny nearly one-half of the prior authorization requests for LTAC and IRF admission and thereby trigger a resource-intensive appeals process, which further delays enrollees from transferring to the next appropriate level of care. We are deeply concerned that CMS's proposed neutral contractor sides with MA plans nearly 100% of the time during the appeals process. NALTH and the American Medical Rehab Providers Association make the following recommendations. There must also be clear and consistent enforcement by CMS to uphold existing Medicare Advantage rules. We urge greater congressional oversight, particularly as how plan behavior is reviewed by an entity that is designated to function as an independent manner. In closing, I want to convey the urgency my LTAC colleagues and I feel as we watch our industry shrink. Absent swift congressional action, we expect closures to continue and for patient access to be limited. I fear Randy's outcome would have been very different had he lacked the access to specialized services like those offered at Madonna. Thank you again for the opportunity to testify, and I'm pleased to answer your questions.
Thank you, Mr. Fleece. You are now recognized.
Good afternoon, Chairman Buchanan, Ranking Member Doggett, and the distinguished members of the subcommittee. Thank you for having me. Chairman Buchanan, please accept my heartfelt gratitude for your leadership to the state of Florida and the United States of America. I'm Jonathan Fleece, President and CEO of Empath Health, one of the nation's largest not-for-profit home-based care organizations, which is proud to serve and honored to serve 1 in 5 Floridians receiving hospice care today. Empath is also a proud member of the National Alliance for Care at Home. I hold a BA degree from Emory University and a Juris Doctorate degree from St. Louis University School of Law with a certificate in health law studies. It has been a privilege to be serving in healthcare for over 30 years. Losing my daughter at birth shaped my mission to ensure that no family navigates serious illness or loss alone. That passion leads me to advocate for patient-centered care every day. In 2011, I co-authored The New Health Age, The Future of Healthcare in America, with futurist David Houle, examining how healthcare must evolve to expand home-based care solutions. That, too, is why I'm here today, to speak for millions of Americans who rely on home-based care and the policies that make it possible. At Empath, we witness and deliver profound care at home every day. For one senior patient with advanced cancer, choosing hospice was not giving up. It was choosing to live fully on her terms. She bravely forewent aggressive treatments that would have kept her in and out of the hospital, away from family, and instead embraced care that is focused on comfort and dignity at home. Hospice helped her avoid countless ER visits. Her husband of 60 years had the support that he needed to make confident decisions, knowing that expert care was just a phone call away. Instead of spending her final moments in a hospital bed, she was home, spending time with her grandchildren, often surrounded by them with love. Her choice gave her quality of life and spared her family the financial burden of medical interventions that could never have changed her ultimate outcome. But home-based care isn't just for those actively dying. It supports people managing chronic illness, recovering from surgery, navigating terminal diagnosis. Patients want it, families need it, and taxpayers benefit. Keeping patients at home prevents costly hospitalizations and reduces strain on the healthcare system today. In a time of financial and workforce challenges, we should be expanding access to care at home, not cutting it. We call this at Empath full life care, a holistic, patient-centered approach that provides the right care at the right time in the place they call home. But today, access to this type of care is at risk. Hospice providers face immense pressure, thin margins, excessive audits, and ineffective fraud enforcement. Bad actors exploit gaps in oversight, while high-quality providers face excessive scrutiny. The flawed Hospice Special Focus Program, built on incomplete data, risks destabilizing trusted providers instead of targeting those who truly abuse the system. Put bluntly, there are hospice programs in the United States that receive Medicare dollars today but refuse to submit their quality and survey data to CMS. That practice should not be tolerated and fuels greater fraud and abuse by allowing some hospices to profit while avoiding transparency and regulatory scrutiny. As a CEO, I understand that financial strength and balanced budgets are essential for both organizations and nations to thrive. As Congress navigates today's budget challenges, in closing, I urge you to consider: invest in home-based care. Data shows it improves outcomes and reduces Medicare spending. 2, expand pay for performance, reward the high-quality providers, and hold those who evade accountability responsible. 3, enhance proven value-based models of care. These are not just policy decisions, they are urgent threats to access, quality, and patient choice. Decisions here will shape the future of care at home. Let's protect and expand access before it's too late. Thank you, and I stand ready to answer your questions.
Thank you, Mrs. Grabert. You're recognized.
Chairman Buchanan, Ranking Member Doggett, and members of the subcommittee, I am Lisa Grabert, a visiting research professor in the College of Nursing at Marquette University in Milwaukee, Wisconsin. It is truly an honor to sit on this side of the dais, as I have spent many hours behind you as a former staffer of this, the most powerful committee in the U.S. Congress. I have dedicated the past 20 years of my career to improving the Medicare program, and I applaud the committee for addressing this important topic of post-acute care. The Medicare program is on an unsustainable path. The Part A, or Hospital Insurance Trust Fund, is projected to be insolvent in 6 years. One factor driving cost is spending across the post-acute baseline. On an annual basis, approximately $60 billion in taxpayer dollars are spent to deliver services to Medicare patients in these 4 unique settings. This baseline has been very profitable for providers. In 2022, the marginal profit was 27% for home health, 27% for nursing homes, 39% for rehab hospitals, and 18% for long-term care hospitals. The average across the post-acute baseline is 27%. In 2013, Congress initiated a public, transparent policy process whereby the chairman and ranking members of the Ways and Means and Finance Committees posed 64 questions to stakeholders. The main goal of the Impact Act, after multiple rounds of consensus building, the Impact Act was signed into law a year later via unanimous consent in the House and in the Senate. The main goal of the Impact Act was to establish a unified post-acute care prospective payment system, or a PAC-PPS. Congress mandated the Centers for Medicare and Medicaid Services, or CMS, to deliver the operational specifications of a payment system that was ready for implementation. To lend credibility to the effort, the Trump administration included a unified PAC-PPS in its fiscal year 2021 budget proposal. The reform would have saved $80 billion in the 10-year budget window if it had been implemented. In 2022, CMS submitted the unified PAC-PPS technical prototype to Congress. In summary, the unified PAC-PPS is ready for enactment, and I strongly urge Congress to give CMS the authority to implement. Justifying regulatory relief within the post-acute care space, given the average 27% marginal profit, will be challenging. For example, the 60% rule around the 13 conditions for rehab hospitals may be a prime target of repeal if coupled with a unified PAC PPS. As policymakers, you should consider your role as masters of the art of the deal. On behalf of the U.S. taxpayer, I implore you to negotiate a favorable outcome in exchange for any regulatory relief. What is an example of a favorable outcome? You guessed it, a unified PAC PPS. Although we have readily available information about fee-for-service post-acute care margins, the Medicare Advantage margins remain elusive. However, my economic intuition tells me we can reasonably assume post-acute care providers do not enjoy an average 27% Medicare marginal profit from MA plans. Unlike fee-for-service Medicare, MA plans cannot exert monopsony power over post-acute providers during the negotiation process. Empirical evidence supports the spillover of fee-for-service payment rates to MA. To address the gap in managing post-acute profits, MA plans may be using other tools in their toolbox, including prior authorization. The HHS Office of the Inspector General found that rehab hospital discharges are among the top services subject to prior authorization by MA plans. The OIG also found that 75% of audited rehab hospital stays were not overturned on appeal. In addition to the lack of medical necessity, the 39% fee-for-service rehab hospital marginal profit may be related to the use of prior authorization of these services. Gaining greater transparency into how MA plans use prior authorization is essential for a better understanding of how lack of payment reform on the fee-for-service side impacts Medicare Advantage. Authorizing a unified PAC PPS could result in an equilibrium that reduces the use of prior authorization by MA plans. In conclusion, I strongly recommend that this committee move ahead with legislation that gives CMS the authority to implement a unified PAC PPS. Thank you for the opportunity to share my perspective within the subcommittee. I look forward to continuing to work with you on these important issues.
Thank you, Mr. Carlson. You are now recognized.
Thank you, Chairman Buchanan, Ranking Member Doggett, and subcommittee members. I appreciate the opportunity to testify on these important topics. My name is Eric Carlson. I work as Director of Long-Term Services and Supports Advocacy for Justice and Aging. I have specialized in long-term care, Medicaid, and related issues for over 30 years. In today's post-acute environment, two issues have special urgency. They are, number one, maintaining adequate funding for the Medicaid program, and number two, implementing nursing facility staffing standards that were announced by CMS last year. I'd like to address threats to Medicaid first. The current House budget resolution calls for the Energy and Commerce Committee to reduce funding by $880 billion over 10 years. A CBO analysis shows that cuts of that magnitude would have to be taken largely from Medicaid, resulting in catastrophic consequences for the program and the older Americans and persons with disabilities that it serves. For many older Americans, post-acute care is not a matter of weeks or months. They have ongoing chronic conditions, Alzheimer's disease, most common example, and that require daily hands-on assistance as well as health care and other services. Only Medicaid covers these services on an ongoing basis, and Medicaid is flexible enough to allow needed services to be provided either in a nursing facility or at home. Crucially, Medicare does not pay for these services, so Medicare beneficiaries rely on Medicaid for long-term care. Of the persons covered by Medicaid for long-term care, over 60% are Medicare beneficiaries. Without Medicaid, many older Americans would be in a hopeless situation. Nursing home care costs over $100,000 per year, and the expense of either nursing home care or at-home care can consume a person's life savings in very short order. Continued funding of Medicaid with its current structure is essential for ensuring that older Americans can access needed long-term care. And then moving to the second issue of particular urgency today, this concerns decades of inadequate staffing in nursing facilities. Finally, last year, the federal government issued a rule to establish reasonable minimum staffing standards, but there's legislation in both houses of Congress to eliminate those standards before they even come into effect, and also to prohibit CMS in perpetuity from issuing similar standards. From a resident's perspective, insufficient staffing means that a resident develops a bed sore because staff isn't available to help them move, or they become malnourished because aides aren't there to help them eat. These are real-world consequences. The hundreds of thousands of nursing facility deaths during COVID highlighted long-standing problems. Studies have found that nursing facilities with poor staffing suffered higher COVID death rates. And studies for decades have concluded that low staffing correlates with a variety of bad outcomes, including bed sores, falls, weight loss, and infections. A related staffing problem has been the relatively limited use of registered nurses. The federal nursing facility law has required registered nurse staffing for only 8 hours a day, while studies have shown improved resident outcomes from higher levels. In the aftermath of the many COVID nursing facility deaths, CMS commissioned a study, issued a proposed rule, and then finalized a rule with new minimum staffing standards. These standards require a registered nurse around the clock. Also, a facility must provide at least 3.5 hours of direct care assistance per resident per day, which must include approximately 2.5 hours of care per resident per day from an aide. Just put this into context briefly. This nursing aide staffing requirement translates effectively to 1 aide for 10 residents. So it's not an extravagance, it's really a minimum standard to ensure that aides are not overwhelmed by the time-intensive chores that they must complete. Most important context is that these standards will save lives. Researchers at the University of Pennsylvania estimate a savings of 13,000 lives annually. There have been a lot of provider attacks for the provider lobby on this regulation. I mentioned the pending federal legislation, but there are also several accommodations that providers have already been given, an extensive phase-in period until 2026 and 2027, which for rural areas is extended to 2027 and 2029. There are hardship exemptions for providers who face labor shortages, as long as there's a good faith effort to meet standards by the provider. And CMS has developed a nursing facility staffing campaign to increase the availability of aides and registered nurses. So in conclusion, if you're talking today about ensuring access to post-acute care, the highest priorities are protecting our current system. On behalf of Justice and Aging, I urge Congress to retain the Medicaid program with adequate funding in its current form and to retain the vital nursing facility staffing requirements. Thank you for this opportunity.
And thank all our panelists for the testimony. We now proceed to the questions and answer session. Mr. Smith from Nebraska, you're now recognized.
Thank you again to our panel, our entire panel, certainly members for paying attention here today. I think these are important topics, and I'm glad that we can convene and discuss these. It's, I think, important to remember that America is a big country, different needs in different places. Yes, I represent a rural district, and rural means different things in different places across America. And in fact, it means different things in different places across my own district. That Nebraska as a whole, which my district is most of the land area of Nebraska, we only have 3 long-term care hospitals in the entire state. They're all in the east. The population certainly is weighted that way, but that doesn't mean we don't exist in other parts of the state. And so it is my hope that we can pursue policies that are more flexible, that actually meet the needs that exist in more parts of our country than we currently do. It's come to my attention that even small oversights in our current policies can have a very significant impact on an individual's ability to access post-acute care. For example, patients with primary immunodeficiencies are typically unable to receive necessary IVIG treatments because facilities are simply unable to absorb those high costs of their special therapies with a standard skilled nursing facility payment. That's why I introduced the PI Post-Acute Access Act last Congress to include these treatments in a limited list of high-cost outliers which are paid outside of the standard skilled nursing facility payment. I want to mention that I frequently hear from Nebraska hospitals about their frustrations with delays discharging patients ready to leave the hospital because of their inability to gain access to an appropriate post-acute care site. Some of those delays are caused by administrative issues such as prior authorization, but in many cases this is because there just aren't any skilled nursing facility beds available nearby for a patient who really needs one. One way to address this lack of access would be to look at new, innovative ways to expand the universe of hospital discharge options. I'm currently working on a new bill which would create a skilled nursing facility at home option modeled after the success of the ongoing hospital at home demonstration. Since the COVID pandemic, we've seen just how much new technologies have expanded the ability of patients to receive care in their homes instead of the traditional facilities. We hear a lot about various things. We heard earlier reference about nursing care staffing mandates by the previous administration. I would say those were political decisions, very expensive ones, I might add, and it has really stressed, if not caused the closure of many nursing facilities, or certainly would if allowed to continue. But I'm concerned that the stress is on facilities, especially in rural areas. The federal government ought not make it even more stressful, especially with unfounded mandates that come out of Washington. I think we can do better than that. American people expect us to do better. But Ms. Grabert, you mentioned the impact of a unified post-acute payment system could have on the post-acute landscape. How would such a system make it easier to provide a skilled nursing facility at-home option for our seniors?
Thank you for the question, Mr. Smith. I do think that what you've described is a perfect model that fits under the umbrella of regulatory relief that can be done in tandem with the Post-Acute Care Unified PAC PPS. It's a model that would thrive under such a system.
Okay, thank you. Mr. Dongilli, again, thank you for your participation here today. Legislation was proposed last Congress to address several key concerns of long-term care hospitals, which included a number of different provisions, such as admitting patients from critical access hospitals, concerns with the high-cost outlier payments, ensuring access for patients with certain complex conditions, and other payment modifications. Which of these do you think would have the greatest impact on your ability to continue serving long-term acute care patients at Madonna?
Thank you for the question, Congressman Smith. Both of those issues would allow greater access for individuals to come and receive services in a long-term care hospital. The high-cost outlier issue is one that is dramatically impacting both access for patients to come into an LTAC, but also the ability for an acute care hospital to manage their ICU and other beds. Currently, when an individual is on a ventilator, say, and requires additional high-cost services like dialysis, for instance, losing $77,000 before receiving an outlier payment because that patient has stayed so long because of the care that they need would deter that LTAC from admitting them. And as a result, that patient might have to stay longer in the acute care hospital and hopefully transition out of receiving the dialysis service before they could admit into the LTAC. Okay. So addressing the high-cost outlier provision would allow greater access, but so would allowing patients to come directly from a critical access hospital. Both are important.
Very good. Thank you again, and thanks to our entire panel. I'll yield back.
Mr. Doggett, I yield to you.
Thank you very much. Thanks to each of our witnesses. Dr. Dongilli, I've been out to a long-term care hospital, I think similar to the one that you operate with Dr. Prettyman, who's here with you today, and seeing firsthand the big challenges you have to provide quality care to people that really need extended care. And I was alarmed by your written testimony, I didn't get to hear all of the oral, that the discharge rates to long-term hospitals are about 40% lower for those enrollees that have Medicare Advantage versus those in traditional Medicare. When someone is not approved by their Medicare Advantage plan to come to a long-term care hospital of the type you direct, what happens to them? What care do they get?
One of two things can happen. They can continue to receive services in the short-term acute care hospital, which often does not provide the comprehensive services that a long-term care hospital provides, with dedicated respiratory staff, interdisciplinary teams, and an integrated care plan. Or they can stay in the hospital for a period of time and then decrease to a facility that is less intense, that might not have those resources in place to meet their needs, and languish there, or perhaps transfer back to the short-term acute care hospital because of the lack of that care.
Well, I think Medicare Advantage is a real problem for taxpayers since they get overpaid, as has been pointed out by the independent MedPAC, and it's a problem in terms of quality of care in this situation and others. Perhaps they've been able to maintain this position where they don't save taxpayers any money, they cost us billions of dollars in providing lesser care by the fact that they invested in this Congress $330 million in lobbying expenses between 2020 and 2024. Dr. Madison, we have visited previously about the challenges that home health care faces in Texas. I know you're aware that if Texas legislature that is already pretty stingy with its Medicaid program has to cut it even more because more responsibility is shifted to the state, that, just like the Medicare issue, will impact what you're able to do with home health care. And I suppose overall my feeling is, Mr. Smith referenced the legislation last year. It's entirely unclear to me, especially on the long-term care hospitals, why it is we're having a hearing in March when I thought we were going to get legislation up for consideration last fall. But I suppose that's the troubling position we're in of inattention to these issues. Certainly, Mr. Carlson, I'm pleased that you focused on the nursing home standards. You have emphasized the impact, and I want to explore that with you a little more. It's been referred to as a political decision, and I suppose that's right. There was a political decision that it was worthwhile, as predicted and estimated with these standards, that we could save about 13,000 lives a year by properly staffing our skilled nursing homes. The conditions have become so bleak that the average nursing home is today turning over more than half of their staff every year. We don't have a true workforce shortage. We have a shortage, I believe, of decent working conditions, wages, and fair treatment of care workers. Nursing homes have the funds to create better working conditions. Again, referring to MedPAC, their 2023 report found that skilled nursing homes have profits that exceeded 10% for 22 consecutive years and were as high as 17%. And that's with them finding that 1 out of 5 facilities have more than 100% of their costs fully met by Medicaid. I just ask you whether there are sufficient workers out there to meet these minimum staffing standards, despite the claims of the industry to the contrary.
Thank you. The first, of course, is the context of this is really important and necessary to make sure that residents get the care that they deserve. As I mentioned in the testimony, there have been numerous accommodations written in the regulation to make sure that this is practicable. The standard selected is not as high as certainly some people advocated for. It's a standard that's already met by 60%. The overall standard is a standard that's already met by 60% of the facilities in the country. There's a significant phase-in period that allows facilities for rural facilities until 2027 and 2029 to fully meet these standards. And also, as I think you rightly point out, this is a retention issue to a significant extent. There's a vicious cycle in nursing facilities sometime where you're short-staffed and then terrible working conditions, and then people leave and you're short-staffed. The idea behind this regulation is to staff appropriately so it's a good environment for residents and for staff members. And then finally, I'll note that there, as I mentioned, there is a hardship exemption if facilities try and make their very best effort. There's a demonstrated labor shortage in that region, and the facility shows that they have offered prevailing wages. They are exempted from penalties for this provision. So in these multiple ways, the standards recognize reality and balance the need to provide good care with the other factors that have to be dealt with and understood.
Thanks to each of you.
Mr. Kelly, you're recognized.
Thank you, Chairman, and thank you all for being here today. What I really like to do when we get in these hearings, I'd rather have people that actually do the work than people that read a couple pages and then say, I'll come up with a really great question. And the business I'm in, the most expensive part of everything we do is paperwork, and it's like redundant time after time after time. So Dr. Murphy and I were talking as we were sitting here. I said, Doc, you know what I'd rather do? I'd rather cede my time to you. Now, but you know the way we break this up in 5-minute increments, I don't want him to lose the consistency with it. So these are business models. And quite frankly, you folks are in this business. I don't know how you do it. You're being mandated by people who have no idea what they're mandating for you to access nursing people that need to be there. And by the way, there's not enough of them to do that. And a lot of them left hospitals and went into visiting nurses for obvious reasons. But if I can, I want to cede my time to Dr. Murphy. He spends his whole life on this. And it is a business model. And it's a failing business model. And I mean what I said. People who don't know what they're doing are setting mandates for you. That's a terrible model. It's a terrible business model. It's probably part of the reason why we're in the situation we're in today. But Dr. Murphy, I would like to cede my time to you.
Thank you, Representative Kelly. You know, I find it interesting on some of our documents. I've been in medicine now for 35 years, and I'm looking at some of the documents here, and I know this is absolute Greek to my fellow colleagues who don't know what this is, what a SNF is, what a long-term care facility. And truth be told, it's a little Greek to me, because whenever I'm in a hospital, and in my field, urology, we do mostly outpatient stuff, but we still sometimes do long-term. If we have to do cancer therapy, somebody needs long-term care, or we consult on somebody that needs long-term care. And then if you look at the tyranny of what our government has done in the rule after law after law, no wonder the medical system in the United States is screwed up. No wonder it is. Because if you have so many different regulations, when I was chief of staff of our medical center, 1,000-bed level 1 trauma center, we had, during my 3-year tenure, 3 different rules about how an outpatient person would be categorized. Whether they're overnight, whether they have to stay 2 nights in a hospital, whether they can go to a SNF, or you literally have to keep them in a hospital an extra 2 days just so that they'll qualify for some of these things. And this is where I am beyond ecstatic that we have a president and a government that is actually willing to step back and look at this nonsense. Because frankly, before I came to Congress, once I got here, I said I would go down to CMS, which, by the way, nobody's been in the parking lot for the last 4 years, that I'd go down and fire 1/3 of the people, because it is rule after rule after rule created so that they have something to enforce. And I say this not only on the hospital side, but I also say it on the physician side. In our practice, we have grown and grown and grown individuals to try to put laws or to try to enforce regulations that were put forth by the government. You look at all of these things. There's no stability in this whatsoever. And if you look at the number of folks who are now employed by the hospital that are administrators, and you compare the growth of them versus the growth of actually the people who take care of this, why is this delta occur? It is because of CMS, it is because of government. And Mr. Carlson, I'll go back. You know, you talked about the nursing home mandate. There's so many disqualifiers. If we could find the nurses in any corner of the country, we'd be happy to do this. But we have beds at our institution that are closed, that are desperately needing to be opened, because we have folks sitting in our emergency room for 36 hours waiting for beds because we don't have nurses. It's fine, I'd want that higher level of care, but we literally, number 1, can't find them, and 2, can't afford them. I'll go back to some of the other remarks that were made. You know, in North Carolina, from April to September of last year, at least 360 patients were medically cleared for discharge but did not have appropriate post-acute care placement. So what happens? They sit in the hospital, and what happens? Not only do they get nosocomial infections, they get infections from other people. Ding, 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 it rings up the bill. Ms. Grabert, I have a question for you in a second. Look, I think Medicare Advantage is making a steal on everything here. I'll agree with Mr. Blodgett on the other side of the dais here. Medicare Advantage will start with a great intention, but is absolutely determined that they're going to steal the taxpayer dollar hand over fist, and United Healthcare is the #1 offender from what's happening from my vantage point, and I think a lot of the federal agencies also. The average wait time for the patients that I talked about, Mr. Chairman? Can I continue? Okay. Average wait time for the patients was 73 days. 73 days for these 360 people. 51% of the patients waited over a month, 25% waited 3 months to 2 years. Guys, I love the concept of home health because I think that's where care is done best, if at all possible. Ms. Grabert, I was astounded by the numbers that you gave about the profit margins of some of those. And I look at the problems here. We're trying to actually get the physicians to not get cut more and more from pay that have happened over the last 20 years. 62% of Medicare beneficiaries were waiting for a skilled nursing facility placement. 44% had serious mental or substance use disorder. So the system is broken. For all those crying out that we can't do this to Medicaid, we can't do this, this system is broken. 1 to 3 years, we're going to have a financial insolvency of our country. Medicaid desperately needs to be reformed. All the cuts and all the scare tactics from the other side of the aisle, patients are still going to be cared for. But if the Biden administration finally would let us audit the Medicaid rolls, which they didn't do for 4 years, we would get people off the Medicaid rolls that don't deserve eligibility. Our psychiatric hospitals in North Carolina had the longest wait times whatsoever, 197 excess days. So we have a problem with getting people from the hospital to the care that they need. For every 3 Medicare beneficiaries waiting in a hospital, 2 out of the 3 are involved in a Medicare Advantage plan. The largest 3 MA plans denied prior authorization requests for post-acute care level at higher levels than did any other types of care. So yeah, maybe our fee-for-service Medicare needs to be fixed, but good Lord, our Medicare Advantage plan needs the wrath of God to come down and fix that system. Ms. Grabert, in your view, let me ask you this. If you're a hospital administrator, if you're a physician, if you're a nurse administrator, what do we do to streamline both discharges and prior authorization requirements? Because there's an entire cottage industry that we have to alert our nurse managers when we think that patient's going to be able to leave. I mean, heck, as soon as I put scalpel down, it's like, when is the patient leaving? So tell me how we streamline that process.
Thank you so much for the question. One of the things that you mentioned, I believe you referenced the 3-day stay requirement in an inpatient facility that's required before Medicare coverage into a skilled nursing facility. I think this is a perfect example of something that is in statute that is really causing some of these issues on an inpatient basis. So I totally share your concern regarding this specific rule. To repeal that rule could be very cost prohibitive. So what you need to take...
What do you mean? Can you explain that?
The reason the rule is in place is because it prevents switching of benefits between Medicare and Medicaid. And so to control fee-for-service utilization, that rule is in place to push down utilization.
So we keep people in the hospital longer?
Yes.
So they're at more risk for DVT, nosocomial infections, et cetera, et cetera.
That is the unintended consequence of the policy.
Yeah, and that costs more money because it makes people sicker, and guess what? They stay in the hospital.
Yes, and your point is well taken. The way that the Congressional Budget Office, unfortunately, looks at that, they're only
All right,
taking...
don't even say CBO around here because I don't believe anything they say. Sorry about that.
The way that they sort of consider that, they probably would assign a pretty cost-prohibitive score to repeal that rule. Because that is their perspective on that particular policy, you may want to also consider the revenue to go along with that to offset it. And that's why I describe things like the 3-day stay as regulatory relief. you could possibly generate the revenue from a unified PAC PPS.
Right, but that's when people are given DRGs, they're paid for this diagnosis, they're staying in the hospital. It could be 3 days, it could be 300 days. The hospital still gets stuck with that bill. So how do we cut down the regulation? How do we cut down the burdensome administrative paperwork? We take an axe to it. And this is where CMS, again, this is what this government has done. And this is Republican and Democrat problem. This is what's happened in every agency, and this is why I'm so glad we're finally having a reset of our government, is to look back and say, this is ridiculous, because it's add upon, add upon, add upon, add upon, and things just don't make sense for patients or the people who care for them anymore. I'm glad, I appreciate everybody's remarks today. I hope we get to the point where we're not just making remarks, but we're actually fixing what is a badly, badly broken American medical system. Thank you, Mr. Chairman. I'll yield back.
Mr. Thompson, you're recognized.
Thank you, Mr. Chairman. Thank you for calling today's hearing, and I want to thank the witnesses for being here today. Although I think it's ironic that we're holding a hearing today on long-term care facilities while the House Republicans are in the process of cutting $880 billion from Medicaid. 63% of all long-term care patients rely on Medicaid coverage to pay for their care. These cuts to Medicaid will hurt 26 long-term care facilities in my district, which provides services for 8,000 patients, half of whom rely on Medicaid. And it's not just patients who will suffer from these cuts. Long-term care facilities support 8,500 jobs, pay $548 million in salary, and contribute $183 million in federal and state taxes. As soon as the Republican budget was announced, I met with healthcare professionals in each of the 5 counties that I represent. What they told me should concern everyone on this dais and every American. They said that the Medicaid cuts in the Republican budget would hurt people on Medicaid and also veterans, people on Medicare, and people with private insurance. These drastic Medicaid cuts will mean 54,000 fewer people will be covered by Medicaid, or CHIP, also known as the Children's Health Initiative Program in California. Rural hospital closures will lead to longer drive times and more preventable deaths in emergency cases. The large hospitals that are able to stay open will cut specialists, leading to fewer local treatment options for Medicaid recipients as well as people with private insurance. I also heard that larger systems will pull back on support for long-term assistance and programs to help keep people in their homes. Without Medicaid-funded equipment, some people with disabilities will be unable to get out of bed and go to work. Some will not be able to stay in their homes, which will mean a higher cost to taxpayers. These Republican Medicaid cuts would cause a $2 billion reduction in economic activity in my district alone. That hurts Main Street. Mr. Chairman, I know that members on this dais will object and say that Medicaid and Medicare and Social Security aren't mentioned once in the Republican budget, but as you know, you can't cut $880 billion without touching those programs. And along those lines, I'd like unanimous consent to enter into the record this news article where Mr. Musk is talking about going after and cutting Social Security. And these are all life-saving programs, and they're being dismantled. The health and the economic impacts are going to be felt in every congressional district and by every American. Can I get you?
Yeah, without objection.
Thank you. Mr. Carlson, please expand on how Medicaid cuts in the Republican budget would impact people who are on Medicare, private coverage, or are veterans who use the private health care system.
Thank you. The important thing to note is that Medicare is not comprehensive. I'd like to focus on that it doesn't cover long-term services and supports on a long-term basis. There's some nursing facility coverage, but as mentioned, only after a hospitalization of at least 3 nights and only for a particularly intensive level of nursing care. So Medicare doesn't cover these long-term service and supports that people need, either in a nursing facility or particularly, as you note, for at-home care. It's worth noting that at-home care is particularly at risk from the cuts that are proposed. These home and community-based services are not mandatory under Medicaid. They're optional programs, and they're particularly vulnerable to cuts like this. If the cuts of the magnitude that are being proposed were to come into effect, states would have to look at their Medicaid programs and make drastic cuts, and it's very likely that those would fall heavily on the home and community-based services programs that are optional. And these are the programs that provide care at home. They provide home modifications, they provide personal care assistance, they provide home-delivered meals, they provide daycare. So all of that care in particular would be at extreme risk if cuts like this were to go into effect.
Thank you very much. And I just can't tell you in strong enough terms how concerned, upset, and unnerved constituents are across the country about this proposal. Thank you. I yield back.
Ms. Chu, you're recognized.
Mr. Carlson, while the topic of today's hearing suggests interest in improving health care for seniors, Republicans are charging ahead with their reckless plans to cut as much as $880 billion from Medicaid. Medicaid's the primary source of payment for long-term services and supports in this country. It's impossible to ensure quality care while gutting the very program that pays for long-term care services for roughly 9.3 million older adults and people with disabilities. Without Medicaid, most older adults who need help with daily activities would not be able to afford home-based or nursing facility care. Medicaid also helps older adults pay their Medicare cost sharing and covers vital benefits that Medicare does not, such as dental, vision, hearing, and non-emergency medical transportation. Over 900,000 older adults and people with disabilities receive coverage for essential long-term services and supports through Medicaid or Medi-Cal in California, including at-home care and care in institutional settings. At $83,000 per year for out-of-pocket home care and $147,000 annually for nursing home stays, long-term care is unaffordable without Medicaid. Medicare only pays for limited days of rehab after a hospital stay or for in-home skilled nursing care if the beneficiary meets the strict definition of being homebound. And most non-skilled long-term services and supports such as personal care or routine care are paid for privately or provided by unpaid caregivers until individuals deplete their savings and eventually become eligible for Medicaid long-term services and supports, which is why cuts to Medicaid are so damaging for Americans who need long-term services and support. And this includes people like my constituent, Chi Kwang from Monterey Park, California. When he heard about Republicans' plans to cut Medicaid, he called my office and said, I am a 74-year-old who's worked for 40 years as a warehouse worker. After decades of hard work, I now rely on Medicaid and Medicare for life-saving medication and medical care, especially after undergoing hip and spine surgery. I also heard from people like Bailey from Alhambra, California, who said, my daughter has a rare genetic disorder and many health problems. I'm worried about what will happen to the help that I'm receiving for her through Medicaid. Without this, it will be impossible for me to take care of her alone. Mr. Carlson, I've read the documents of Justice in Aging, and I am very interested in what it has to say about the interaction between Medicare and Medicaid. How would Republicans' Medicaid cuts affect the ability of seniors who rely on both Medicare and Medicaid, like Chi Kwang, to afford their health care? How would these cuts affect people with disabilities like Bailey's daughter in accessing long-term care services?
Thank you. I can make some additional points to the answer that I made a second ago. As you noted, Medicaid helps people pay Medicare premium, so the Medicare savings programs, that's something that's used by 10 million older Americans to cover the significant expense that the Medicare requires, for example, the Part B premiums, which are $185 a month. So there's significant expense that Medicaid helps with that otherwise many people can't cover. I'll note also that Medicaid, given the really high long-term care expenses that you note, is a lifeline for people really from a multiplicity of income levels. You can have significant life savings and be middle class or thereabouts or above. And if you find yourself at a need for nursing facility care, paying private pay at $100,000 a year, you spend down to Medicaid levels very quickly. So Medicaid is just a rock bottom safety net program that provides something that no other program provides for the folks like your constituents that you mentioned, people, older people and individuals with disabilities who need this kind of long-term service and supports, whether it be in a facility or at home. Medicaid is the only thing that's available for them. They can't afford it otherwise. Medicaid specifically pays when otherwise people can't afford it. And so the cuts that have been proposed here would be devastating for the Medicaid program and devastating for the people that rely upon it.
Thank you. I yield back.
Mr. Hearn, you're recognized.
Thank you, Chairman. I really appreciate you doing this today, holding this meeting, and I appreciate all the witnesses being here as well. Post-acute care is an integral part of the healthcare system. It's where patients have the chance to really heal and get back home to resume their daily lives. One piece of the system is long-term care hospitals, also known as LTACs. LTACs were where the sickest patients go, as you all know, spending an average of about 26 days there. There are 2 LTACs in my district back in Oklahoma, not in the whole state of Oklahoma, and I'm concerned about the rate of closures we've been seeing in the LTAC industry in the past few years. While I applaud the work of Congress and what they did in 2013 to address overpayments and misaligned incentives in the LTAC system, we are now a decade out, and it's time to look how we can modernize and improve the work that was done. That's why, alongside my colleague across the aisle, Representative Boyle, introduced H.R. 1924, the Securing Access to Care for Seniors in Critical Condition Act of 2025. This bill ensures the sickest of patients are getting the care they need without unnecessary delays, and that LTACs are getting paid the appropriate amount for these patients by helping clarify what constitutes an LTAC payment. The goal of this legislation is to get patients the setting of care they need when we know they need it. Mrs. Grabert, thanks first of all for being back. I'm sure you're happy to be back in this room, and at least for a moment anyway, so thank you for all your work over the past under the former chairman. I know you have a lot of experience in this space, and can you tell us what Congress can do to ensure we get patients to the correct place of care, whether it be an LTAC, an IRF, or SNF, you gotta love the names, or any other place of care they need, as quickly as we can get their healing process started? And what are some of the unnecessary delays we are seeing in getting these patients to where they need to go?
Thank you for the question, Mr. Hearn. And congratulations on the bill that you introduced just last week for regulatory relief for long-term care hospitals.
A bipartisan bill, I might add.
Yes, a very nice achievement. And it's a classic example of what I would classify as regulatory relief, the same type of policies I'm talking about that would be essential to pair with a unified post-acute care prospective payment system. So I do think those things could go together very nicely. And I think specifically long-term care hospitals could thrive under a revised payment system. So I encourage you to think about that type of reform and pairing that with the wonderful bill that you introduced last week.
Thank you much. Mr. Dongilli, I appreciate all the suggestions for improving the LTAC payment system, and that's why I've introduced my bill to provide a small bit of certainty for the industry. However, I want to ask you about the current statutory provision that specifically grandfathers just a few LTACs from some of changes that have happened over the last few decades.
And do you believe that we should address these grandfather provisions as we look to modernize LTAC payments?
My understanding of the grandfathered hospitals, they have shrunk. I think there's 8 or less, maybe in the country right now. Those LTACs are not exempt from these payment requirements or the criteria for admission into the LTAC. They really center on the hospital within hospital provisions about common ownership and common control. So I don't think dealing with that would have any impact on allowing greater access into the long-term care hospital. One thing that I do think would allow greater access into the long-term hospital is dealing with this Medicare Advantage issue. And I'll use this patient example. We have 2 patients that look exactly alike, both on ventilators, both have stayed in an ICU for 3 days. One has Medicare Advantage, one has traditional fee-for-service Medicare. Our staff go in and evaluate those patients. The fee-for-service Medicare patient we can bring right in, no delay, because they meet the criteria that has been set by CMS, by Congress. The Medicare Advantage patient, we need to get prior authorization, we need to go through, they're usually denied because they say they can receive care in the short-term acute care hospital. They go through an appeal process. Now, you might say that impacts us, but think about that family. And we have often had this input coming from family members. They visit with each other. They're in the rooms right across from each other, and one will say, how come that patient can go to Madonna, but my family member can't? Well, it's because you have a Medicare Advantage plan, and they're delaying your admission, and they're denying it. So I think that is the key crux of what could happen short-term to address this problem.
Thank you, and obviously pre-authorization is a whole other subject for another day, and really appreciate your thoughts on that. Thank you so much. I yield back.
Mr. Evans, you're recognized.
Thank you, Mr. Chairman. Mr. Carlson, post-acute care is very expensive in all of its forms. Those who receive it often have even more complex cases. Can you speak to that issue?
I'm sorry, could you repeat the question, please, sir?
Post-acute care is very expensive in all its forms. Those who receive it, it often has even more complex care. You speak to that?
Thank you. There's a great deal of complexity, and Medicaid is an important provision that allows people to get to where they need to be. There's been discussion here about levels of care in different parts of the healthcare system for low-income folks or people who spend down to Medicaid eligibility levels. Medicaid is essential for providing the care that is needed, whether it be in a nursing facility at whatever level. It could be a more intensive type of care, the kind of care that's been referenced here. And it can also be the type of long-term assistance at home, for example, that individuals might need on an ongoing basis. Medicaid, working along with Medicare for many people, allows the basis to be covered, as it were, so the individual can get the medical care, the physician care, for example, or the hospital care that he or she needs, but also the long-term care that might be necessary as well.
Can you please elaborate further in how much even those enrolled in Medicare often still rely on Medicaid aid to meet their needs while in post-acute needs?
Thank you. As mentioned earlier, that the people who receive Medicaid-funded long-term care are 60% Medicare beneficiaries. So the programs are, in a practical matter for those people, the programs are set up to work together. It was mentioned, Medicare, oftentimes when people approach Medicare eligibility, they just assume, well, no, I'm covered, I'm 65. Medicare will cover me, but that's not true. It was mentioned by some of the other witnesses, even that Medicare won't cover a nursing facility care unless you have a qualifying 3-day stay in a hospital. There are various provisions like that that limit the ability of the Medicare program to meet the needs of real people, and specifically the post-acute, the topic of our conversation here today, in long-term service and supports. Medicaid is essential to fill that role because Medicare will not. And for older people and for other adults with disabilities, Medicaid is essential because it's the only program for those folks who are unable to pay privately that allows them to cover the long-term service and supports items that they need to live a full life.
Mr. Chairman, I'd like to thank you.
Thank you. Pursuant to the committee's practice, we will now move 2-to-1 questioning. I recognize Ms. Miller.
Thank you, Mr. Chairman, and thank you all for being here today. Rural patients, like my constituents back in West Virginia, are disproportionately left without critical support that they need to recover after major illnesses. But it also is from surgery. This lack of access to essential care not only affects their recovery, but it also increases their risks of complications, leading to longer hospital stays and a diminished quality of life. One way to address this critical gap is to expand telehealth usage in post-acute care settings. I introduced the Hospice Recertification Flexibility Act, which passed out of this committee last year. My bill would allow hospice providers to use telehealth to conduct face-to-face visits required for hospice recertification. Mr. Dongilli, not only do patients suffer from a lack of proximity to necessary care, but their families and spouses are also deeply affected. For caregivers and loved ones, the inability to regularly visit or assist in the recovery process can lead to emotional, financial, and logistical strain. With these challenges in mind, will you speak about the impact of lack of access to care in rural areas upon your patients' spouses and families, and the challenges that they face visiting their loved ones?
Well, thank you for that question. It is a very real issue for family members. We recognize that treating patients in post-acute care is not just treating that patient, it's treating the entire family. It's making them comfortable and confident to take their family member back home once they finish their episode of care. And so I know we've tried to institute various ways to make it easier for those family members to access the care we provide at Madonna. We provide some family housing. We have the ability for family members to stay in the patient's rooms. They have access to amenities that would support their relocation for brief periods of time, to our vicinity. I think that the part of the bill that Congressman Hearn talked about and that you also co-sponsored is making it helpful and useful for folks to come to an LTAC and for that LTAC to receive payment for them, admitting directly from that critical access hospital. And so that would hopefully help the patients and their families receive the care that they need.
Thank you. Long-term care hospitals are critical for patients who require extended care. The cost to treat the complex medical needs that the LTCH patients require can be significant. The reimbursement system for the LTCHs is structured to help manage these costs, but recent changes to the high-cost outlier threshold have introduced new financial challenges. By raising this threshold, the amount of reimbursement LTCHs can receive for treating particularly costly cases has decreased. This puts additional strain on providers, and it affects the level of care available to patients. I introduced the Patient Access to Long-Term Care Hospitals Act, which will provide adequate reimbursements for LTCHs. My bill also caps the high-cost outlier amount to $50,000. With this in mind, Mr. Dongilli, what has been the impact of the increase in the high-cost outlier threshold for LTCHs on providers, such as yourself, and the patients you treat?
Well, from a provider and patient perspective, prior to the increase, the significant increase in the high-cost outlier threshold, for instance, when it was $27,000, I know from a financial standpoint, we were able to allow more patients who would enter into the facility who we knew would become high-cost outliers, because that fixed loss amount was such that we could manage that and still make a relatively small margin within our long-term care hospital. And at that time, it was close to 4%. When that doubled and it went to $58,000 or $57,000, what we saw was that we had to provide more scrutiny, even though we continued to admit those patients who would go into high-cost outlier status. The financial impact of doubling it resulted in our overall LTAC margin falling from that 4% to a -3%. So when you're talking about a significant number of cases, and for us at that time, our high-cost outlier threshold was about 30%. So now we have to limit that in order to just maintain financial solvency, which denies patients access to the care that they need at that point in time.
Thank you for your answer. I have to yield back. I'm out of time.
Thank you. Mr. Fitzpatrick, you are now recognized.
Thank you, Mr. Chairman. Thank you all for being here today. A key challenge facing my constituents back home in Bucks and Montgomery County in Pennsylvania has been the increasing staff shortages in the healthcare industry, forcing many patients to be turned away for necessary care or alternatively to receive suboptimal care to meet their needs. This is coupled with increased pressure on the professionals administering this very care. As has been brought up in this hearing, staffing for these specialized post-acute care facilities is especially concerning in my home state. In Pennsylvania, PA is projected to have the most dire shortage of staff for skilled nursing facilities by 2026. And reportedly, nearly half of Pennsylvania Healthcare Association members plan to close or sell at least one of their SNFs this year. Dr. Madison, in your professional experiences in home health, can you speak to how staffing has changed in recent years, and moreover, how have these potential challenges impacted your ability to treat your patients?
I certainly can. Thank you for the question. In Lubbock, Texas, 6 years ago, we did a study, and at that one point, we're a city of 260,000. We were 1,000 RN short and 1,000 LVN short, and that's a backfill hole that that's a hole that you can never backfill enough. So we are dealing with it right now. Telehealth would help with that tremendously. If we could do telehealth visits, one particular nurse could make 20 visits a day instead of the normal 8 that they make. For those patients that don't need to actually have hands-on care that day, I think telehealth would be a great way to take care of those patients. We also lost a lot of nurses during COVID because they did not want to be subjected to some of the viruses and stuff that are out there. And then also you have disabled nurses that can no longer handle the hospital care work that's demanded of them. We could put them to work also.
And Mr. Dongilli, in your experiences and observation, are you able to speak to how staffing concerns have impacted your administration of care?
Yes, like Texas, and the state of Nebraska in 2025 is forecasted to have a shortage of RNs of over 5,000. And so you can't absorb that. And so I think what we find within my state is holding beds that could potentially be opened if we had adequate staff. It's widespread, not only in the post-acute sector, but in the acute hospital sector as well. So it does impact the provision of care and patients' access to it.
And moving on to long-term care hospitals, these hospitals play an essential role in caring for our seniors with serious conditions. Ms. Grabert, several years ago, Congress created the criteria for LTCH eligibility, requiring a patient to have an ICU stay or 96 hours on a ventilator for an LTCH to receive a higher payment. What was the rationale of this change?
Thank you for the question. I believe part of the rationale behind it was that the Medicare Payment Advisory Commission had recommended to Congress to put patient criteria into place for long-term care hospitals. MedPAC recommended an 8-day ICU stay, and when Congress legislated it, they codified a 3 ICU day. So I believe that that was some of the background behind how Congress got to the 2013 policy.
Got it. And back to you, Mr. Dongilli. Are there patients who might benefit from an LTCH care who do not meet this criteria? How would this change impact their care?
Well, thank you for that follow-up question, because yes, we can understand the reason to create criteria, but we believe that 3-day in the ICU stay went too far. There are other patients who are critically and chronically ill who could benefit from the services that a long-term care hospital provides that haven't maybe been in the ICU. There are certain hospitals, for instance, one hospital in our Marquette right now has 25 patients waiting in the emergency room, waiting for a patient bed. Some of those patients can get into a unit within the hospital that can deal with their critical chronic condition instead of the ICU, but because they're not in the ICU, because of the bed availability, they're not then eligible to come to the LTAC. So we think they should be expanded.
Thank you, Mr. Dongilli. I yield back, Mr. Chairman.
Mr. Horsford, you are recognized.
Thank you, Chairman Buchanan, and to the ranking member. Medicaid, as we're discussing today, is the primary payer for long-term care here in the United States, covering about 61% of total spending. It's the backbone of our long-term care system, supporting millions of seniors and individuals with disabilities, as well as the dedicated professionals who care for them. But let me be clear. Despite some mistruths circulating from my colleagues on the other side of the aisle, the impacts of the 2025 Budget Reconciliation Plan, I call it the Screw America Bill, are indisputable. House Republicans are proposing to slash $880 billion from Medicaid and eliminate critical tax credits that help working families afford their health care, all while delivering a $4.5 trillion tax credit cut to billionaires, to big corporations, and to tech tycoons. The consequences of these proposed cuts are not hypothetical. They are catastrophic. Any cuts to Medicaid will only intensify the existing challenges in the long-term care sector. Direct care jobs will become even harder to fill, further straining the system. Providers will be forced to reduce workers' hours and in some cases shut down entirely, destabilizing the long-term care workforce and undermining health care quality. Workers themselves will be at risk of losing their own Medicaid coverage and other essential supports, further plunging them into financial instability. Now, my constituents are very concerned. Just this past weekend, I held a town hall to give an update on what's happening here on Capitol Hill and to listen directly to my constituents. The first question from that town hall: what is being done to protect workers in nursing homes from Medicaid cuts? That is not an abstract policy debate. It is real. Real workers, real families, and real lives that are on the line. Mr. Carlson, my question is simple. If $880 billion in Medicaid cuts become a reality, what do you anticipate will happen to the long-term care workforce?
If cuts were made of that magnitude, then long-term care providers couldn't operate the way they can now. You can imagine closures that because of the prevalence of Medicaid to fund long-term services and supports, drastic cuts to Medicaid would, first the consequences fall on the state, which is unable to make payments that are necessary to maintain the system, and then the consequences fall on the providers because they no longer have the funding to provide necessary services on an individual basis, on an institutional level. A lot of nursing facilities and also home community-based services providers rely extensively on Medicaid. 50% of the reimbursement, 2/3, depending on the, or above, if you're talking about some home community-based service providers, they just couldn't operate any longer.
So knowing that reality, what should lawmakers be doing right now to protect these workers and to stabilize the critical workforce that's needed in healthcare?
Yeah, well, on behalf of Justice and Aging, that the urgent issues in access to post-acute care at the topic of today's hearing is protecting the Medicaid program, in rejecting these cuts, in recognizing the importance of Medicaid and maintaining the current funding and structure of the program.
And this is the fact that even before this House Republican reconciliation proposal was made, families were long voicing concerns about the quality of care in nursing homes, especially the lack of adequate staffing to meet residents' needs. In fact, in 2024, the Centers for Medicare and Medicaid Services took action and set minimum staffing standards to ensure that every facility has a nurse on site. Research from the University of Pennsylvania shows that the rule improves care quality, reduces abuse, and saves an estimated 13,000 lives annually. But now Republicans have indicated their desire to roll back these critical protections once again to fund tax breaks for big corporations and the wealthy. So how is rolling back protections and standards going to improve quality, Mr. Carlson?
Again, the position of Justice and Aging is that it's counterproductive. I'll note that this has been a problem for decades, that the standard of the federal government has just been sufficient staffing, which hasn't been enough to establish a decent quality of care. And you can talk to individual nursing facility residents and hear stories all day long about just not enough staff and how that leads to bad outcomes and a bad quality of care. Just point out, the standard, there's a phase-in period, right? It hasn't even come into effect yet. And so what we would advocate, of course, is that let these standards be implemented. They're important. There are accommodations to allow for changes under certain circumstances, and they should be maintained.
Thank you. I yield back.
Mr. Kostoff, you're recognized.
Thank you, Mr. Chairman. Thank you for holding today's hearing, and I do want to thank the witnesses also for appearing today. Mr. Fleece, if I could with you, in your opening testimony, you talked about the workforce shortages in the healthcare sector and how those shortages are affecting access to care. Can you tell me, in your experience, how common is it for somebody to enter the workforce as a CNA to pursue a higher level of nursing, like becoming a licensed practical nurse or registered nurse?
Thank you, Congressman Kustoff, for that great question. I will share, as the CEO of a hospice and home-based care organization that employs over 3,400 workers a day, that those healthcare workers are my first and foremost attention every day. And after the great resignation in healthcare that occurred during the pandemic, the runaway inflationary pressures that have hit healthcare since and going on forward since then, the pressures to hire, retain, and recruit staff are immense. We are absolutely reinvesting in workforce development as an organization at Empath, and certainly always very grateful for Congress's support for funding workforce development efforts. But it is a major healthcare crisis in the United States today. Across the entire system is adequate staffing in healthcare.
Thank you. Mr. Dongilli, if I could with you, if a skilled nursing facility receives certain high-level deficiencies or a fine up to a certain dollar amount. As I understand, that facility probably can't offer or will not be able to offer CNA classes for a certain period. I think it's 2 years. So hypothetically, if Madonna were to lose that ability to hold CNA classes, how would that affect your ability to be able to staff your facility? How would you be affected?
Well, it would impact negatively our ability to have the CNA staff that we need in order to provide the patient care we're known for. So it's important, and we would hopefully not find ourselves in that position.
Sure. The district that I represent is a mostly rural district in West Tennessee. So in my district, there are a number of counties where the local nursing facility might be the only place that they could, somebody could obtain or take CNA classes. So would you say it's fair to say that for a nursing home, maybe like the kind that I just described, that losing the ability to hold those CNA classes would inhibit or impair their ability to be able to improve the quality of service?
Yes, I would say it would.
Thank you very much. Dr. Madison, I know that Medicare reimbursement for remote patient monitoring services is subject to price modification based on average cost to operate in a given geographic area. Now, this takes into account factors like employees' wages, office space, equipment, and the cost of offering remote monitoring is not necessarily cheaper in rural areas like the kind that I represent. And in fact, it might even present additional challenges like connectivity or broadband or longer travel times to set up equipment. Can you talk about how home health services like yours offer rural RPM if reimbursement for these services was in line with the national average? Does that make sense the way I asked that?
I can tell you as a home health agency that we're currently offering remote patient monitoring. We offered blood pressure, weight, and glucometers for our patients. We do not get reimbursed at all for those services currently, but we feel like it's necessary in order to provide better care, especially because we can see if there's an issue a lot faster. The devices that we use, we've not had trouble with connectivity. It's Bluetooth, and it's much easier than it was 10 years ago. Let me put it that way.
Good. Thank you, Dr. Madison. Thank you to the witnesses, and Mr. Chairman, I yield back.
Mr. Moore, you're recognized.
Thank you, Mr. Chairman. Ms. Grabert, the University of Utah in my district has provided data that indicate that of the patients that require specialized post-acute care, the majority require either home health care or skilled nursing facilities. MedPAC has long indicated that there is sufficient access to home health care, but many people are saying that access measure is flawed. Could you shed some light on this? Should MedPAC adopt a new measure of access? If so, what elements should this measure incorporate?
Thank you for the question, Mr. Moore. No, I don't think MedPAC's measure of access for home health is flawed. I support MedPAC's methodology. Is there any ways to, as we look at the approach to this, any ways that you would suggest we improve this? Certainly, I think access to care issues are always something in the Medicare program that we need to pay attention to. I don't have a specific recommendation for you today, but I'm happy to follow up with your staff after
Excellent.
today's hearing.
Thank you. And like my colleague, I represent several rural counties, Mr. Fleece, particularly in northern Utah. In many cases, telehealth is the best option for Medicare patients. How does Empath Health employ telehealth services to improve quality? What are some of the best practices that may be employed elsewhere? This is obviously a big topic that we're going through here in Congress, and we've had multiple times where this is going to expire, and we've done it temporarily. Like, share a little bit about how you would approach this.
Thank you very much, Congressman Moore. And Empath Health prides itself at serving the rural communities across Florida. Telemedicine is a critical part of ensuring access to care, whether it's recertification of hospice eligibility or ensuring that in crisis that we can get access from communications perspective to all of our patients. It's also mission critical to our home-based care organizations, those that are suffering chronic disease or post-acute, to ensure that home-based care is there for the rural communities through telemedicine to reduce hospitalizations, readmissions that home-based care has been proven to demonstrate. And we are also always looking for additional infrastructure investment to ensure that not only do we have telemedicine from a policy perspective, but we are able to connect to the rural communities, whether that be through satellites or other technology that Empath invests. It's not just policy, it's also infrastructure from a technology perspective that is mission critical to reach the rural communities.
Excellent, thank you. Lastly, Dr. Dongilli, post-acute care facilities nationwide were operating at approximately 85% capacity back in, say, 2019, obviously before COVID-19 exacerbated much of those resources. Can you shed some light on current post-acute care capacity? Does our current post-acute care infrastructure have enough beds for patients in need?
I think that for the most part, beds are available. Why we're seeing shrinking access is not so much the bed availability, it's the inadequate payment or the restrictive criteria that are used in order to allow those patients to access. And I'll cite the Medicare Advantage challenges as a prime example of that fact.
Excellent. Thank you. Appreciate it. I yield back.
Mrs. Sanchez, you're recognized.
Thank you, Mr. Chairman, for holding this hearing, and I want to thank our witnesses for being here today. Post-acute care is a critical part of the care continuum, but it's often fragmented in its delivery, so I'm encouraged to hear the witnesses' ideas to help address some of these issues. Something that I personally care deeply about is long-term care. More often than not, caregiving is unpaid and it's provided by loved ones. 2/3 of caregivers in the United States are women. And I've worked for over 10 years to pass a caregiving tax credit, and today my colleague, Mr. Carey, and I reintroduced the Bipartisan Credit for Caring Act. I hope that we can pass this on a bipartisan basis to provide much-needed relief for working families, because the only other way working families can afford long-term care is through Medicaid. And Republicans are hell-bent on pursuing an $880 billion cut in Medicaid to pay for the tax cuts for the largest corporations and highest income earners in the United States. The fact is that 3 out of every 5 nursing home residents rely on Medicaid. Mr. Carlson, I want to thank you for your testimony on long-term care and your notes on staffing standards in skilled nursing facilities. I want to ask you, and if you could answer briefly, because I've got a lot of territory to cover, what kind of impact would Medicaid cuts have on access to nursing facility care?
Thank you for the question that has been mentioned. Nursing facility residents, you're talking about close to 2/3 of residents who are reimbursed by Medicaid. And so that's just obviously a tremendously big piece of reimbursement for nursing facilities. So any dramatic cuts to Medicaid funding, as I mentioned earlier, the consequences fall to the states. They don't have enough money to do what they want to do. What needs to be done to cover the healthcare needs of older.
So the individuals would be responsible. Can many of them afford that?
Yeah, I mean,
on
then
their own?
right. Then it falls on the facilities aren't adequately reimbursed, or the eligibility standards are changed. One way or another, it becomes untenable for everyone. The providers, it's likely become untenable.
But I'm focused on the patient. What happens to the patient?
For the beneficiaries, they either don't have coverage, or that the financial standards would be such that they couldn't afford to
and so they wouldn't
the
get
care
the
that they needed.
wouldn't get the care.
Yeah, you get squeezed out.
They wouldn't get the care. They'd be squeezed out. And what would that do to the nursing home industry in states like Alaska, Georgia, Louisiana, or West Virginia?
Those are states which is an even higher percentage of Medicaid benefit. I think north of 70%.
So $880 billion cut in Medicaid would mean that those facilities and their patients who are no longer receiving the subsidies, what happens to those facilities?
The impact is even bigger in those states because the percentage hit on nursing facilities is that much higher. There's not enough money for individuals, there's not enough money for providers.
Okay. Thank you. I want everyone to recall when my Republican colleagues on this committee voted to rescind the minimum staffing rule for nursing facilities last year. Our own chairman said in his opening statement during our markup last year, quote, "Without access to more staff, nursing homes, particularly those in rural areas, will have no choice but to reduce the number of residents they admit or shut down altogether." Let me repeat that. Without access to more staff, nursing homes will shut down. So let me ask, are Republicans still outraged about rural nursing facility closures? Because an $880 billion cut in Medicaid will close many of those rural facilities. So I urge you to stand up to oppose those cuts, which will devastate those rural facilities and the patients that they serve. I also want to talk about access to issues in post-acute care. This is an issue that I've worked on a bipartisan basis with Ms. Van Dyne of this committee, and I'd like to submit for the record our letter on MA network adequacy standards, which still do not include IRFs.
So ordered.
Thank you, Mr. Chairman. I also consistently hear that patients experience long delays in post-acute care due to Medicare Advantage's plan's prior authorization practices. Mr. Dongilli, in your testimony, you cite improper denials in coverage for more intensive post-acute care. What causes delays in care when a patient transitions to the post-acute setting at an IRF?
Thank you for the question. The delays result from the process that has been set up by the Medicare Advantage plan. Like I said previously, fee-for-service Medicare patients, we can assess that patient and bring them in within 1 day. If it's a patient who has Medicare Advantage, we have to take that clinical information, we have to provide it to the Medicare Advantage plan for approval to bring the patient in. Often what we see is an immediate denial.
And how often are those prior authorization claims denials appealed and overturned?
They're appealed and overturned?
Yes.
Overturned. What we find in our experience is that roughly maybe 40% of the ones that are initially denied can be overturned during appeal.
Thank you, and I yield back.
Mr. Stubbe, you're recognized.
Thank you, Mr. Chairman. Mr. Fleece, thank you for all the work that you've done in my district. The number of home health providers has declined significantly. Excluding California, the number of agencies serving beneficiaries has dropped by 17% since 2019, from 7,793 to 6,468. A publicly traded home health company recently announced the closure of multiple agencies, particularly in rural areas, citing reimbursement cuts as the primary reason. Can you provide insight into the factors driving this widespread closure of home health agencies? And do you believe current reimbursement policies are sustainable for providers?
Thank you, Congressman Stubbe, and we do thank you for your service to the district where Empath Home Health serves, as well as Tidewell Hospice, so thank you, sir. Ultimately, home-based care is so much of the solution to many of the questions and many of the problems that have been identified today at this subcommittee. Ultimately, as I co-authored in my book, The New Health Age, how we think about healthcare, how we deliver healthcare, and the economics of healthcare must change. And there are many, many reasons behind that. I concur that there are various models within the home-based care environment that are driving especially smaller home-based care agencies out of business, and even for larger not-for-profit organizations like myself, caring for 80,000 Floridians a year, Programs like PDGM, programs like Review Choice Demonstration, the complex OASIS tool that our staff are forced and required to comply with, while well-intended when enacted, certainly do require further consideration to reduce administrative burden, to ensure that home-based care and patient care survives. And in all due respect, in my final comment to one of my panelists that's testifying today, I practiced healthcare law for 25 years and have been in healthcare for 30, serving as a CEO or president of this organization, and I'm hard-pressed to find a lot of home care agencies as identified by MedPAC with 20+% margins. We are operating at a 2%, that's 2% net operating margin across Empath Health and the care continuum, and our home health care division is operating at a net loss.
And under the new home health payment systems, are payments covering providers' cost?
Absolutely not, Congressman.
And how inadequate are fee-for-service payments relative to cost?
Inadequate. And when Medicare Advantage is continuing to grow, while there are good implementations and 5-star rated Medicare Advantage plans across this country that has been longstanding, we need to continue to move towards a pay-for-performance model and also pay the 4- and 5-star hospice and home health agencies more so that we're paying for performance under the model.
And can you speak to your experiences with prior authorization? Are most of the requests approved? How does this impact the care received?
So I would ask for the Congress here today to imagine one of your loved ones in either hospice or home health, and they are in need of post-acute care. Every second, every minute is critical to get them out of the hospital into a home-based care environment. We both participated under the Medicare Advantage carve-in pilot on the hospice side, and we contract with Medicare Advantage plans today. It adds hours, days to the pre-authorization process and delays access and delays care. Oftentimes on the hospice side and sometimes even on the home care side, patients literally die during the discharge planning process waiting for the authorization, Congressman.
In the little bit of time I have remaining, is there any issues you'd like to address that you haven't had the opportunity to address so far?
Thank you so much, Congressman. One thing I can guarantee every congressperson here today is that we will all die. If I compel you to take one takeaway today from this subcommittee hearing, it's preserve the end-of-life care benefit that hospice has been known for over 45 years in the Medicare benefit. Thank you so much.
I yield back. Thank you for being here.
Mr. Fleece, let me ask you, you've built an enormous organization, Tampa Bay area, obviously the biggest part in Sarasota County, my colleague's district, but I've watched your growth, your professionalism. What is the key to your success? I think you're one of the top facilities, organizations in the country. And so as you look back in your tenure, and I remember about 20 years ago, you gave me a copy of your book, by the way. Time goes by so fast. But what's been the key to your success, or a couple of keys with your organization? It's one of the best run organizations in the country.
Thank you so much, Congressman, for that great question. And I, too, am extremely proud of Empath Health as we serve Central Florida, Southwest Florida, the East Coast of Florida, and as you stated, over 12,000 patients a day in our care. I think, number one, the secret of our success is always put the patient first to everything that we do. The staff are also mission critical, because if we are not investing in taking care of our staff, we will not have workers to care for ultimately the patients. As I have already stated, we understand within our industry that we as a country are in challenging economic budget times. It is critical that we look at this as a return on investment conversation. Hospice care has shown over and over and over again that it will ultimately reduce Medicare spending. 25% of the Medicare spend is spent in the last 6 months of Medicare beneficiaries' life. 25%. Of that 25%, 10 to 15%, a small component, is spent on hospice care. If we look at this as a return on investment conversation, there is so much that can be done around home-based care so that we are getting patients and families out of an institutional environment where they do not want to die, where they can be cared better for to reduce hospital readmissions, so that we can continue to expand care in the home.
You touched on performance to pay. I know being in business 30 years before I got up here, that was a big premise of mine, is trying to make sure we tied the behavior to what we were trying to incentivize people. Can you explain what you mean by that from your perspective?
Yes, Mr. Chairman, Congressman Chairman. If you look at the current star rating system that is prevalent in Medicare today, it is one that does not adequately pay for performance the providers that are providing care for patients today. We would certainly advocate that for those organizations that have higher star ratings, that they get paid more under the reimbursement system. That would be one model of a pay for performance. We also stand proudly behind taking risk through our PACE programs, programs for all-inclusive care for the elderly, where we are ultimately caring for those that would otherwise be in a nursing home and receive both the Medicaid and the Medicare component for our PACE programs. And we become responsible for that performance. We become responsible for making sure that they have the right care, right place, right time. And finally, Mr. Chairman, I would advocate that those that are not reporting their survey scores, to avoid scrutiny, be rooted out, because much of the fraud and much of the profiteering that we are seeing in America today, that we know the Special Focus Program was proposed to address, are not submitting their survey scores. That is required so that those of us that are providing high-quality care can continue to focus on our mission.
And my last question is on preventative care. That's really my focus with this committee as much as I can. Don't get sick in the first place. I mean, you get sick at some point, but my point is, you touched on that too, preventative care. What does that mean with your organization, with your patients, people that use your facilities?
Thank you, Mr. Chairman. So many of what we are talking about today is how we can improve outcomes for reduced cost. And ultimately, that will be part of what Congress faces in its upcoming budget discussions, I am sure. One of the concepts around thinking and delivering healthcare differently is the more that we focus on prevention versus being reactive, and the more we focus on wellness versus sickness, there is a return on that investment. That will help balance this nation's budget.
Thank you, and Mr. Smucker, you're recognized.
Thank you, Mr. Chairman, for holding this important hearing, and I'd like to thank each of the witnesses for sharing your testimony today. You've explained how important post-acute care is, how vital of a role it serves in our nation's healthcare system, with roughly 40% of Medicare beneficiaries receiving this type of care after inpatient hospital stays, and we've also talked about how that helps them to recover and stay healthier for longer. I've spoken to constituents in my district about the services that they've received through skilled nursing facilities, home health, patient rehabilitation facilities, and other care settings, and understand and agree with the importance of continuing to make improvements to the Medicare program so these services continue to be accessible for all seniors. I'd like to highlight just a little bit the LTACs, or long-term care hospitals, which serve the most complex patients who are in need of specialized care but are facing waves of closures. I've heard that from folks in my district as well. And these are the hospitals that, or if these closures continue, the patients with the most severe conditions won't have the level of care that they need. We've heard reports of Medicare Advantage plans delaying or denying coverage. You've mentioned that earlier today for LTAC services. Why I believe that MA has been a game changer in allowing seniors to that access to better, more comprehensive health coverage. I'm concerned by some of the obstacles to care, which could lead to costly complications for patients. So, Mr. Dongilli, we've heard a little talk about prior authorization just a little bit ago, but can you describe some of your experiences with prior authorization and talk about how those may create barriers to coverage and how that impacts the care that your patients receive?
Yes, thanks again for the question. The delays once an assessment is done on a patient who has Medicare Advantage and working through the appeal process is time-consuming and resource intense. It delays that patient's access, and at times, the patient then and the hospital that's referring them may not want to work through that process with us. And so as a result, we'll discharge the patient to a less intense setting where they don't receive the care that they need, or they stay in the acute care hospital and create throughput issues for that hospital because they can't discharge them.
So it literally could lead to patients being required to leave your facility and not receiving the care that is needed.
Correct.
Yeah. I appreciate you sharing that. I'd also like to touch on home health as well. We know that patients recover quicker, have better experiences when they receive care in their homes. Occupational therapy is one of the services that seniors can receive through the Medicare Part A home health benefit. However, as you know, the outdated statute prevents occupational therapists from treating a patient in their home unless they're accompanied by another provider, which creates a strain on medical providers and complicates this access to care. Yesterday, I introduced a bill with Mr. Doggett and several other colleagues to streamline the process and allow occupational therapists to provide standalone services in the home health benefit. Dr. Madison, you also noted in your written testimony that on average, one 60-day period of care of home health costs less than one treatment in an emergency room. So I would think there are huge cost savings here. So Dr. Madison, how would a bill like the one I've described streamline patient access to care? And can you expand on the financial implications this would have for the Medicare system?
Yes, sir. We're paid for an episode of care, regardless of what services we provide. However, if OT could stand on its own, then an OT could provide all the services needed instead of a nurse having to do the admission and the discharge. So it would.
Can you give any sense on what kind of cost savings that would create?
It would not, because we get paid for an episode. We get paid based on the diagnosis, the function of the patient, that kind of thing. What it would save is the expenses that the agency is having to spend.
Yes. All right. Thank you. Mr. Chairman, I yield back.
Mr. Byer, you're recognized.
Mr. Chairman, thank you very much, and thank all of you for hanging in here. It's been really encouraging to hear many good ideas about how to provide better services to patients in those latter years of their life. And I really want to thank you for being here to discuss supporting older Americans. Today, more than ever, Americans are working into their later years. And these changing conditions require new methods of support. I'll lead a bill to establish an Older Workers Bureau within the Department of Labor, supporting our older workers and ensuring they have the resources they need to succeed. You probably know this is the fastest growing sector of our workforce. And those resources are needed to confront the unique challenges that older workers face. Things like work-limiting health conditions or financially preparing for retirement. And for many older Americans, that difficult balance is only made possible because we have critical federal programs like Social Security and Medicare. Mr. Carlson, I would like to thank you specifically for discussing the importance of Medicaid to older Americans, which is so often overlooked. And I'm deeply concerned that my Republican friends and colleagues are pushing a defunding bill that actively attacks older Americans. We're expecting to vote on that bill in just a few minutes. This is far from a clean bill. The partisan measure strips away $13 billion from essential non-defense programs and services. That includes cuts to critical medical research, cuts to emergency programs, and even specific cuts to veterans' medical benefits. The bill would cut $280 million in research for treatments and cures for Alzheimer's, despite the fact that 50% of Americans 85 and older will get Alzheimer's or dementia. It cuts research for heart disease, kidney disease, diabetes, and many more serious health conditions that disproportionately affect older Americans. It cuts more money from USDA's Commodity Supplemental Food Program, leaving 25,000 older Americans unable to participate, denying them emergency assistance at a time when food prices are still rising. And it omits nearly $23 billion in planned funding for the Toxic Exposures Fund to care for veterans exposed to burn pits, Agent Orange, and other toxic substances. Those veterans, many of whom were exposed to toxic substances in Vietnam, are older Americans. And they're disproportionately older and face severe health impacts from their sacrifices for our country. And this bill doesn't stop there. Because it lacks any guardrails, it allows the Trump, Musk, Vance administration to continue to stop funding, to impound funding, or redirect funds away from even more programs for older Americans, including home assistance, mental health care, rural health care, and cancer programs. And that's not to mention the budget resolution that the House Republicans have passed to set up reconciliation. To pay for tax breaks for the wealthy, they're looking for $2.5 trillion in cuts. And they charge the Energy and Commerce Committee here in the House, the one that oversees Medicaid, with $880 billion of those cuts. The nonpartisan Congressional Budget Office found that those cuts were not possible without touching Medicaid, which I look at 162,000 Virginians over 65 depend upon. I held a Medicaid roundtable last week in Alexandria, last Friday. We had nursing home managers and owners there. They said it was impossible for them to survive if Medicaid were cut. So, Mr. Carlson, a simple existential question. Put all this together, is it possible to make cuts of this magnitude without undermining the care that older Americans rely upon?
The simple answer is no. The program could not survive in a reasonable fashion given the cuts that have been proposed.
Well, that's enough. And Mr. Chairman, then, I yield back.
Mr. Suozzi, you're recognized.
Thank you, Mr. Chairman, and thank you to the witnesses. I know you've had a long day today, Dr. Madison and Mr. Dongilli and Mr. Fleece, Ms. Grabert and Mr. Carlson. And I wasn't here for most of your testimony. I watched some of it on TV, but I appreciate it. I just wanted to come here and talk about a bill that I'm working on that is pertinent to this issue. As Mr. Carlson mentioned in his written testimony, there are 10,000 people turning 65 every day. And in 5 years, I don't know if that was in your testimony, but in 5 years, there'll be about 6,000 or 8,000 people turning 85 every day. And one of the #1 causes of new homeless people in America is turning 80 years old. And we've got a major storm coming in our country with long-term care. Especially, we can't afford to put everybody in a nursing home. We don't have enough nursing homes, and Medicaid will go bust. And my Republican colleagues who talked about saving money in Medicaid, and I think I'm trying to posit an idea that can save a lot of Medicaid money, but also make people's lives better in the process. And that is to create a public-private partnership on long-term care insurance. I grew up in a house, all 4 of my grandparents lived in my house growing up. 3 were very sick, Parkinson's, Alzheimer's, they called senility in those days, colon cancer, and my other grandfather lived to about 90-something, pretty healthy. And my mother was a nurse, and we all took care of my grandparents. I remember taking my grandmother to the bathroom. You can imagine what that was like when you was a young teenager. And my parents didn't want us to go through that, so they got long-term care insurance. And they lived till 95 and 93, and they died at home, and they had a great end-of-life experience. But most people can't afford long-term care insurance. Only 3 to 4% of Americans have long-term care insurance. And the insurance companies went broke when they issued a lot of insurance policies for long-term care originally, because they didn't take into account the actuarial tables that people would live a lot longer than the average of like 1.5 years to 2 years after you couldn't do your 2 activities of daily living. So we're going to have a major problem in our country. It's already started. It's going to get a lot worse, where we have all these senior citizens that are living a lot longer, that are going to need assistance with activities of daily living. Their families are smaller. The kids have moved to other parts of the country. There's nobody to take care of their parents. And the solution right now is to spend down your assets or, give them to your kids in some way or to your spouse and do spousal refusal, and then stick you in a nursing home and have Medicaid pay for it. It's not only a bad way to end your life, it puts a lot of people into poverty, and it's really a miserable way to exist. So what I'm proposing is that the federal government needs to create a catastrophic care program whereby we will provide long-term care dollars to people if they live beyond a certain period of time. So if you are a lower income person, the lowest 20% of America, you got to take care of yourself for a year between you and your family. If you're a higher income person, you got to take care of yourself for 5 years, and a sliding scale in between that 1 year and 5 years. And by taking care of that catastrophic care portion, it'll incentivize the private sector to create insurance products for long-term care that'll be much more affordable, and they'll be out marketing it the way they market Medicare Part B and things like that now. They'll be out selling these products and letting people know that they've got to deal with this long-term care issue, because nobody talks about it. Nobody talks about these end-of-life issues, and as a result, families are falling apart all over America. Seniors are being left destitute because they haven't talked about this issue. And it's never going to be that the government's going to solve this problem. We have to create a vehicle by which the private sector will be incentivized to go out and market these products that will be affordable for people, that they can get long-term care insurance. So the question is how to fund it. I believe the way to fund it, I originally wanted to do a payroll tax, but I'll never get my Republican colleagues to vote for a payroll tax. So I think there's one of two ways. One is to get the savings that we'll generate from Medicaid, because I believe we can dramatically reduce Medicaid expenses by creating these long-term care products. And number two is to, when there are ideas out there now how to fix the Social Security Trust Fund by investing money, not Social Security Trust Funds, but other money that will get a rate of return that will help to supplement the Social Security Trust Fund. Anyway, Mr. Carlson, do you agree that there's a major problem in our country with this explosion of seniors that's coming on board?
Yes, it's something clearly that has to be grappled with, as you point out, that oftentimes these issues don't get the attention that they deserve, and it absolutely deserves the sort of attention that you're describing here.
Dr. Madison, do you think that Chairman Vern Buchanan is a brilliant, handsome, wonderful guy that will work together with me on the WISH program?
You know,
Absolutely.
Okay. Thank you very much. I yield back.
thank you. I'd like to thank our witnesses for appearing before us today. Please be advised that members have 2 weeks to submit questions to the answers later in writing. Those questions and your answers will be made part of the former hearing record. With that, the subcommittee stands adjourned.